endocrine system, but then again, you know I love all the systems. Endocrine system is awesome. So we will talk, a lot of these are kind of surface. We do go into a little bit more with this chapter. So this is a nice, I'm a visual person, and so it's nice for me to see. You don't have to know like luteinizing hormone and follicle stimulating hormone, but we are going to be talking about the effect from the hypothalamus to the pituitary, and then the subsequent endocrine glands that it affects. So some of the hypothalamic substances produced are released from the anterior, and some of them are released from the posterior. We're also not talking about oxytocin. Basically, vasopressin and the thyroid meds, the adrenocorticotropic meds, and then bone growth meds. The rest of them, we just say, yeah, they're there. We don't need to know those. So, optional. When do we use these? When either it's a diagnostic aid or when there's a hormone deficiency present, obviously. So these are the drugs that we're using to replace anterior pituitary hormones. These are the ones that we're using to replace posterior pituitary. And the reason that comes up because we start talking about primary and secondary, and I've seen some questions, we'll get to that. So let's start with the drugs. This is a synthetic form of this ACTH. So if you go back up here, we have hypothalamus releasing, creating ACTH, which is secreted by the anterior pituitary, which acts on the adrenal cortex. And where does the adrenal glands sit again? On top of the kidneys, right? So let's go down to. So these are some pretty serious deficiencies when you have them. If you don't have cortisol or adrenaline, your body's completely out of whack with electrolyte balances, the ability to maintain your blood pressure. In general, we use these in that stress response. Obviously, adrenaline, that's when somebody's chasing you or whatever. And cortisol has to do with sort of the rhythm of our body, the cycle of it. So we use this synthetic form when we're diagnosing an insufficiency, when either it's our adrenal gland or it's upstream. So sometimes it's up here in the pituitary, sometimes it's down here in, hypothalamus, sometimes it's here in the pituitary, and then sometimes it's down here in the organ. So we're trying to figure out where the problem is. So here's kind of the take-home page. Why do we care about cortisol? Regulates metabolism and our blood sugars. It's anti-inflammatory. It deals with those electrolytes. And the most common side effect is increased blood pressure and edema of the hands or feet. Why is that? It makes sense. But why is it pharmacologically or physiologically? Yeah, because it promotes renal retention of sodium, right? We're going to increase blood volume, we're going to increase blood pressure, and have edema of the hands. So if you know the mechanism of action and what it does, if this is our regulator, we're regulating how the speed at which things go, and we know about this electrolyte imbalance, that the side effects are going to be related to it. So if you have a deficiency, the side effects are going to be related to all these things. You're going to have dysregulation of your blood sugar and your metabolism, problems with inflammation, problems with your blood pressure, being able to maintain your blood pressure. So that's learning, so corticotropin, cosintropin, not cortico, cosintropin is the medicine that's a synthetic form of ACTH. It's used as a diagnostic. That's all we talk about with that one. Cosintropin being the diagnostic for either adrenocortical insufficiency or hypopituitarism. We're summing it up. The next one is the growth hormone replacements. There are a couple of cases where we use it. People who have this deficiency here in the pituitary gland from the growth hormone, so GH is your growth hormone. And obviously, if you don't have enough growth hormone, they have a form of dwarfism that's pituitary. So it's not like achondroplasia, which is a genetic condition, or pseudoachondroplasia. They have a hormonal cause of dwarfism. So if it's caught early, we can give people growth hormone in order to help them achieve proper stature. Super costly. Only $1,800 a dose. So, just write your check to me. Yeah, it's also used for the wasting that comes with HIV, although HIV now is treated as a chronic disease. We don't have a lot of, like we did when HIV was first out and people were wasting away and nobody knew why. So it gets used, it's approved for that use. So obviously, the adverse effects are related to the effects of the drug. If you have something that's stimulating your growth, you might get too much growth. You might gain excess weight. You might gain excess blood pressure. You might have excess blood sugar, right? It's just sort of, you might overshoot the mark. So people who are on growth hormone are going to be monitored to make sure that we're not pushing people into like pre-diabetes because we're giving them growth hormone. The opposite of it is acromegaly, when people have excess growth hormone. Do you know the actor Andre the Giant? Yeah. He's like the famous one who had acromegaly. And so if it's caught early, we can give a different drug that's blocking the effects of the growth hormone, and that one is octreotide. So this is not the primary treatment for excess growth hormone, but just knowing that it does get used for that, you should learn, okay, we give growth hormone when you have insufficient, and we can give octreotide when we have too much. Octreotide gets used in a lot of conditions where there is excess neuroendocrine stimulation. And so some of the conditions, I've had people who've had, let's see, scleroderma of the GI tract. And so they were having profuse watery diarrhea. And so this one would inhibit the neurohormone that was causing it. This is some carcinoid tumors secrete this vasoactive intestinal polypeptide called VIP, which causes this profuse watery diarrhea. So sometimes octreotide gets used off-label for diffuse watery diarrhea because it has a clinical indication in this particular case. So that's obviously side effects are related to the mechanism of action. You can see they're all GI. It's a drug to slow the GI tract. We're going to have GI side effects, not rocket science. So these are some of the monitoring that you have to do. Because it's an inhibitor of growth hormone, it also broadly inhibits glucagon and insulin, so we can end up with some problems like hyperkalemia. Remember that if we don't have enough insulin to drive potassium into the cells, where is the potassium? It's in our bloodstream. It's just floating around out there, making us all hyperkalemic. So octreotide can have that side effect because it's blocking some of our natural insulin production. So if we don't have insulin, we have elevated blood sugars, we may become hyperkalemic. Anytime we're doing anything with slowing, so you can impair the gallbladder's ability to kind of secrete and squeeze. So all of those side effects that we had talked about in the other slide that were GI related. And also just knowing that you don't use it with people who have bad kidneys. But these are the main ones of the, like, what is the nurse monitoring in the hospital? We're monitoring for hyperkalemia, we're monitoring blood glucose, and what do we teach the patients to report? Then let's see, posterior pituitary and vasopressin. So, the hypothalamus makes vasopressin, which is a hormone released by the posterior pituitary, and it's also called antidiuretic hormone. You know what a diuretic is, so an antidiuretic makes you what? Hold on to water, right? Hold on to water. And it's typically used for diabetes insipidus, which is a deficiency, some sort of problem in the posterior pituitary where we don't have antidiuretic hormone. So what are the symptoms of someone who doesn't have enough antidiuretic hormone? If you're going to
lose all the fluids.
You're going to lose all your fluids, right? Polyuria, polydipsia, you're going to be thirsty and peeing all the time. And you can be born with it, you can have a tumor, you can have an accident or trauma. This can happen at any time. So luckily we've learned that we can use it for diabetes insipidus. The two drugs, vasopressin and desmopressin, there are two key differences between them. So vasopressin is a super strong vasoconstrictor. That's where we actually get the term oppressor from. If you say we give them pressors in the ICU to bring up their blood pressure, it's this vasopressin. Desmopressin is a much stronger antidiuretic, but way less of a vasoconstrictor, which is good because we don't want people stroking out on us. So we use desmopressin typically for diabetes insipidus and vasopressin for these cardiac emergencies. It also gets used as a nasal spray for kids with bedwetting. They take a nasal spray and then restrict fluids at nighttime, and it's supposed to help their body hold on to the fluid so that they don't have bedwetting. And for some reason, desmopressin increases clotting factor 8, and so there's this other use to help stop bleeding. So basically, what you have to teach on how to give a nasal spray. You know, like blow your nose first and all that basic stuff. So know the difference between those two drugs and know that if it's diabetes insipidus, probably that's the drug we're giving. Here you go. It's a guy. He was in a traffic accident about 2 days ago, then had a head injury. He was doing fine until he began to have increased pee. He's had, over the past 12 hours, 3 liters. That's a lot of pee in 12 hours. A urinalysis is performed, and the results include a specific gravity of 1.001. Symptoms of dehydration are present, and the patient complains of being so thirsty. The patient's diagnosed with diabetes insipidus. So what's a normal specific gravity?
10 to 10:30.
Yeah. So you should know your normal specific gravity because you may get a question that just throws out numbers like that. Obviously, I mean, you can be pretty confident in your answer, but the patient's family comes to visit. One of them says, will he need insulin now? What do you tell them?
Diabetes insipidus isn't diabetes.
Diabetes mellitus. Diabetes
Yeah.
insipidus isn't diabetes mellitus, right? So you're going to explain to them it's caused by a deficiency of this adrenal hormone, or antidiuretic hormone that was a result of the trauma to his head, has nothing to do with his blood sugar. Because anybody hears diabetes, they immediately think blood sugar, insulin. We went over that. So what treatment do we expect they'll give him?
Vasopressin.
We're going to give vasopressin or desmopressin?
Desmopressin.
Right, desmopressin, because we don't want the vasoconstrictive effects, but we do want the antidiuretic effect. This says vasopressin or desmopressin, but most likely this would be if there were other issues in the hospital. You wouldn't see it really. Desmopressin is the one that we use the most. So if both of them if one of them shows up, choose it. But if both of them show up, I would choose desmopressin over vasopressin. What findings will indicate to the nurse that the medication worked? Yeah, less output, right? You're measuring I's and O's in the hospital, so you're going to have less O. Decreased output, and then the urine-specific gravity should return back into the normal range. This just talks about the mechanism of action, so less thirst, less pee. What side effects should you be watching for?
Purple.
Purple tongue?
And the horn?
And horns? Unicorn purple tongue.
Oh, yes.
So there's a lot of them. Because desmopressin does have vasoconstrictive properties, it's a lot weaker, but it still has it, right? We're going to have some of these that are related to vasoconstriction, like increased blood pressure and headache. Some of them are hormonal, so you end up, the hormonal ones are more like the cramps and, tremor and sweating. So, yeah, they want you to recognize if somebody is having an adverse effect from these medications and what you would teach the patient to expect. Don't teach your men, they're going to have uterine cramping. All right. Thyroid hormones. Oh, man, I love thyroid hormone. All right, so thyroid hormone is pretty cool. So we start in the hypothalamus with the creation of, what's TRH? Thyroid releasing hormone. Okay? So we create thyroid releasing hormone to stimulate the pituitary gland to produce thyroid stimulating hormone, which stimulates the thyroid gland to produce thyroid hormone. Isn't that a complicated, nutty system? So you can have a problem here, you can have a problem here, you can have a problem here. Lots of places can go wrong. If you have a problem here, you have primary hypo or hyperthyroidism. Secondary is here, and tertiary is here. So it works upstream. So let's have a clinical scenario where you're looking at some labs, and the lab that we usually look at is the thyroid Sorry, I have something tickling my throat. Cockroach or something. The lab we typically look at for anyone who is having thyroid issues is the thyroid stimulating hormone. So normal thyroid hormone is somewhere between like 0.2 to 2. This is TSH. So your lab comes back and his TSH is 19. Is this patient hyperthyroid or hypothyroid?
Hypo.
Which one? I hear both.
It's hypo.
I don't know.
Normal.
So is this the actual thyroid hormone?
No.
No. It's hypo. This is the foot on the gas pedal to make the car go faster. So when the thyroid hormone is low, thyroid stimulating hormone is high. And people get a little bit confused about that, but now you're all rocket scientists in thyroid. So if you have a TSH that comes back 19, either they're not taking their medicine or they were on amiodarone, and amiodarone is known to suppress thyroid function. Now you know that because you were just examined on amiodarone as an antidysrhythmic. If it comes back, yeah, this is the most common scenario, which is hypothyroidism. It's way more common than hyperthyroidism. This is like, I'd say 60% of older adults have some form of subclinical hypothyroidism. So what do we give a patient then? Are we giving them thyroid releasing hormone? Are we giving them thyroid stimulating hormone? Are we giving them thyroid hormone? Yeah, we're just going to give them the thyroid hormone. Typically we give the synthetic form because it lasts longer. Like levothyroxine is the number one on the market. Brand name is Synthroid. We typically give out levothyroxine and the body converts it into the active form. So levothyroxine is actually T4, which is an inactive form, but our body immediately converts it into the active form. There are some people who have this idea in their head that they have to have the active form. There are drugs on the market, of course, to meet all of our crazy demands. There are some that are combinations of these two. It really makes no difference because if you're taking T4, your body just converts it to T3. It's really dumb to spend extra money, but people do it. And then there's also desiccated animal thyroid hormone. We try and stay away from stuff like that due to problems with exposure to animal immunogens. We don't want to have an allergic response or something. So thyroid hormone is a slow acting medicine. It takes, on average, 6 to 10 weeks before we're going to check it again, before we're going to check thyroid stimulating hormone. It's just a slow acting medicine. So if a patient misses a day, I just tell them, don't worry about it, take it the next day. I mean, it's such a slow drug. And it's also a slow drug to get out of your system. So if someone has taken too much or we have overprescribed, it'll take a while to get out of the system. So if your patient calls you a week later and says, I've been taking this thyroid hormone for a week and I don't feel any better, what are you going to tell them?
Wait together weeks.
Hold your pants on.
Wait 2.5 months. And then
Hold on there, little chicken. It's going to take a few more weeks. And they should have already had like a lab appointment booked somewhere between 6 to 10 weeks. I never check people before 10 weeks in my practice just because sometimes they haven't reached that plateau of what they've been taking. They may continue to go up, and if you increase the dose, you may overshoot them. So if we overshoot them, that's going to be the side effects of the medicine. What happens if we overstimulate your thyroid hormone? I guess we should start with what are the symptoms of being low in your thyroid?
low blood pressure, low activity.
Yeah, everything's low. I think of the thyroid hormone, so this is my throat right here. It's right there in my throat, as the master controller of the speed at which all body processes happen. This is like, yeah, it's like the gas for the car. The car's going to go slower if there's less gas, and the car's going to go too fast if you, the car's going to go slower if you press off, and the car's going to go too fast if you press down too hard. So low thyroid hormone is very sluggish and slow. Hair loss and weight gain and feeling tired and lethargic and wanting to sleep all the time. And yeah, we all have that problem, but no, nothing's wrong with our thyroid gland. It's just nursing school. So you don't need any thyroid hormone. So the opposite would be true if you were either hyperthyroid or you took too much, which would be the adverse effects. So what would that be if you were the opposite?
Increased blood pressure, activity.
Yeah, tachycardia, tremors, not being able to sleep. Now, we all wish we had, the weight loss and the not be able to sleep and all of that. So the side effects are simply the effect of the drug, but you overshot it. There's another hormone released from the thyroid gland, which is calcitonin, which you may get asked about. It helps regulate calcium levels. And there is a calcitonin medication that you can take for people who have thyroid dysfunction and are not producing enough. So sometimes if the problem is, let's see, well, we'll go back, I have more on this. So here's where we go. Whew, you can see all my arrows and stuff. So primary was abnormality in the thyroid itself. Secondary was upstream in the pituitary gland where you're not secreting thyroid stimulating hormone. And then tertiary was way up at the hypothalamus, which is not releasing thyroid releasing hormone. And probably if it's in the hypothalamus, you have a whole bunch of other hormonal imbalances as well, if your hypothalamus is all messed up. So yeah, this is just the summary of what thyroid does. This is the basal metabolic rate, basically your speed at which everything goes, the speed at which you produce red blood cells, the speed at which you metabolize your meals, your electrolytes, and then calcitonin. I like that one. We already talked about this. This is just a visual: weight gain, constipation, heart rate, hair loss, memory, sore muscles. So we've gone over that. Those are all of the ones that we just got done talking about. And so people who've been hyperthyroid and have had surgical destruction of their thyroid gland because they were hyperthyroid, now we have to give them thyroid hormone because their gland was destroyed. So sometimes we end up causing a problem, but you know, if you have too much thyroid hormone going on, it's either going to be a cancer or an abnormality, and you can't have that. You will burn up your body if you're hyperthyroid and don't treat it. So we can either block it or destroy it. We did that one. So, yep, we already talked about all of these side effects, and they all sound like being hyperthyroid. So now we'll talk about hyperthyroid. So, a couple of choices. We can either block the thyroid from making the hormone, but we still have a thyroid gland that's producing, and now we just regulate this drug, how much we're blocking, in order to have an adequate, in this case, we're going to be monitoring the thyroid hormone itself, making sure that we're regulating the drug to keep that level. Or we just are destroying it with radioactive iodine, and that's when you may need replacement therapy. There is surgery. That's like malignancy, rather than you can have some nodules in here that are benign, but they're overproducing thyroid hormone, and so sometimes we'll use the radioactive iodine to basically kill those little hyperactive nodules. People who are on thyroid hormone will need to be on thyroid hormone for the rest of their life. It's just the way it is. Now, if it's amiodarone induced, then it's as long as you're on amiodarone. But like if it's a drug induced, it's as long as you're on the drug that's inducing it. But that's also a teaching point. Like when your TSH is back in the normal range, that doesn't mean we stop the drug. Now, that's kind of one of those questions they tell you. We do tell people to take it in the morning because it is I wouldn't say a stimulant, but let's just say it gets it's your foot on the gas pedal, gets you going. So you don't really want to take it at night in case you are one of the people who it causes insomnia for because you're all revved up. Take it at the same time of day. Don't switch brands. We do recommend taking it on an empty stomach. And then we also recommend not eating foods high in iodine, because iodine is a necessary ingredient to make thyroid hormone. So we may actually end up overshooting if people are having a lot of soy sauce or iodized salt. So this is all of the teaching. Some of the people that I've, the old farts, their mechanism to remember to take it, because it's really hard to remember to take something by itself at the beginning of the day on an empty stomach before you take all your other medicines. So a lot of them keep the bottle at their bedside, and when they wake up to urinate in the night, they'll take one, and then in the morning they get going, or they keep it in the bathroom. And so, you know, when they get up to urinate at 4 in the morning, they take that. It's on an empty stomach. It's already in there. So it's a teaching, kind of a teaching tool on how you can be consistent in taking it on an empty stomach at the same time every day-ish. This was not what it was supposed to say. This was supposed to say, here are the things that you need to know. So ignore that. I don't know why that happened, but I saved something else. So you should know the diseases that cause hyperthyroidism. There's 3 of them. You should know the term thyroid storm, what it looks like, and how we treat it. And then the complications of untreated hyperthyroidism, because we don't have time to go over all that. So I don't know why. I don't know. Go figure. That's the all of the pituitary and thyroid in a nutshell. How fast we're speeding through this. There are a lot of drugs on the market for diabetes. So this is a chapter that has superficially covers things, and so that's kind of the way we're going to do it, because mostly I don't think they're going to test you in depth on all of the classes of the drugs, but I know that some of them they do pick out. So type 1 diabetics have a deficiency in the production of insulin in their pancreas. This is something that is either born with or happened due to a combination of, we've figured out now it's a combination of viral illnesses and genetics that often, it's an autoimmune disease, trigger your body to destroying your own pancreatic production of insulin. Type 2 is typically related to obesity and inactivity, and we have a ton. So type 1, we only use insulin, although there's new studies out there about another type. But type 2, we try and avoid insulin in type 2, well, at least I do, because insulin promotes weight gain. So insulin makes you metabolize your glucose, and then your cells absorb it all. And so you may have eaten more calories than you should have. Now you're going to absorb every single bit of it. So it promotes weight gain, which is the opposite of what you want, because the disease was caused by weight gain. So if you're taking a medicine that worsens the disease, it's kind of a downward spiral. So there's a lot of other drugs out there that are better. We can actually reduce or eliminate diabetes simply by weight loss. It's well proven, well documented. Type 2, of course. No cure for type 1. But people who lose a large percentage of their weight, and exercise makes our bodies much more sensitive to insulin, and then diet and weight loss just basically make the disease back down. I've had some patients that I say, yeah, you're a type 2 diabetic who no longer has an active disease. No medicines, but they lost 50 pounds. So insulins. So we obviously, everybody knows about insulin. It's in order to convert glucose into a usable form for us to either store or actively use. And the book focuses on rapid-acting insulins for some reason. So rapid-actings are what we call prandial insulin, meaning it goes with your meal. It's intended to treat the elevation in blood sugars that are going to happen because of the food that you're going to eat. They happen, their onset's super quick, they don't last very long, and so you're supposed to give it, like when you sit down for your meal, take this rapid-acting insulin. So we have Lispro, Aspart, and Glucosamine. Those are the rapid-acting. We do have other ones that are short-acting, like short-acting, we have intermediate-acting, we have long-acting, we have mixed formulations, we have high-concentration formulations. They're really just, in this book, particularly asking you about some of these rapid-acting insulins, like When do you teach your patients to take it? No, you don't take it after your meal when your blood sugar's high. You take it before your meal so that it's in your body working as you're eating. Adverse reaction. So what's the most concerning potential adverse reaction of insulin? Right, it's just more of the action of the drug. It's, yeah, hypoglycemia, coma, death, all right. And then this I've already told you, what's an unfortunate consequence of insulin therapy that can make the underlying disease worse. So unfortunately, insulin causes weight gain, which worsens the disease, meaning you need more insulin, which causes more weight gain, which means you need more insulin. Yeah, it's a downward spiral. This is not a very good, this is lipodystrophy, so you can't see it real well. So if you're injecting insulin in the same place over and over and over, you get scarring of the tissue. And scar tissue is not healthy tissue. And it won't absorb the insulin like healthy tissue. So part of the teaching is to rotate your injection sites. Y'all will have work somewhere and talk about, we rotate our injection sites. One patient, he took literally a Sharpie pen and made a graph on his abdomen, and then he would go along. Like, it's not, you don't have to be that specific. He was really trying to be a good patient. Rotate those sites. Otherwise, you end up with this, and I've seen it, people giving their insulin through their shirt. They just go like that. They never see their skin. When I'm doing a physical exam, I'm like, oh, what's this hard scar tissue here? Well, that's where I give my insulin. And his insulin dose is being increased and increased and increased and increased, and it may be because he's injecting it into this scar tissue that doesn't absorb it. So that's one of the reasons why you have the teaching of rotating sites, because patients are famous for just same spot, same spot, same spot. We try and avoid sliding scale. Sliding scale is super old school. It's reactionary, so it's saying, oh, your blood sugar's this, let's give you some insulin to bring it down. It's not the best way to manage blood sugar. We typically do this in the hospital when people are acutely ill, and illness is known by itself to elevate blood sugar. Illness is a stressor. Stress increases blood sugar. And so we typically are only doing this type of thing in the hospital when someone's acutely ill, or if they're getting TPN or tube feeds, because we need to, oftentimes the tube feed and TPN have insulin in them already, but you may need to add a rapid-acting insulin to bring. So this is the example of a blood sugar where, okay, the tech has checked the blood sugar and it was, 351, so you're going to be giving 10 units of insulin. The problem is we're giving it after the fact. The patient's already hyperglycemic, when we should really have been timing it before meals. But in these cases, someone who's super sick, acutely hospitalized, that's where you'll see it. We just get large swings in blood sugars. The current way that we manage insulin now is called basal bolus. So your basal is your long-acting insulin. So this is 0, and this is 24. And so your long-acting insulin sort of comes in and starts to peter out. And at 20, well, it's going to be a little bit longer than that. And at 24 hours, you're going to be giving it again. And so this is your kind of where your insulin is here. Now, here's when you eat. So here's brekkie. You ate and your blood sugar went up and came down. Well, it didn't come down to there. It comes down to maybe here. Then you ate lunch and your blood sugar went up, and then it came down to here. And then you ate dinner and your blood sugar went up, and then it spends all night trying to come back down. So we take the long-acting insulin as the basal to give a baseline blood sugar control. And we take the rapid-acting here right before the meal so that the blood sugar doesn't spike like this. We may only, our goal, let's say this is normal blood sugar. Here's normal, 60 to 90. Our goal is to keep the patient's blood sugar below 60 to 90. There's 90, there's 60. In that range. So here's healthy. Yes. No. No. So we want to give the rapid-acting insulin here so that their peak is more like that. Right? And we give rapid-acting insulin again here, so their peak is more like that. And rapid-acting insulin here, so their peak is more like that. So basal, and then the bolus. That's how we treat diabetes, type 2 anyways. Well, type 1 in some people, but type 2 mostly if they're on insulin. Is this preferred way? They're starting to do it in hospitals more, recognizing that it's the better way to treat blood sugar. And so long-acting insulin along with the rapid-acting insulin for meals. Cool, huh? So awesome. All right, so that's insulin. Rapid-acting, long-acting, that's all we talked about. There are probably another dozen or more insulins on the market. I'm not going to worry too much about it. The oldest anti-diabetic drug is in the biguanide category. There's only one, and it's called metformin. Most people have heard of metformin.
Isn't it to lower blood sugar?
Yeah, these are all anti-diabetic drugs. So drugs that are used to lower blood sugar. And this is the mechanism of action. So it works on the liver to reduce glucose production. It decreases our absorption of glucose, and it makes our cells more sensitive to our own insulin. So it's a pretty cool drug. It's usually one of the first-line drugs for people newly diagnosed with diabetes, unless they're way out of control. But it's often times given. Now, the things you need to know is that the side effect is GI distress. So it does come in a short-acting form and then in a longer-acting form. Like with all meds, we want to start low and go slow. We want to tell them, so typically they might start out on 500 milligrams, tell them to take it with their meal so that they don't get these upset stomach, diarrhea type effects. The problems I've seen is that they get sent home from somewhere on metformin XR, and they're told to take an 850, no, they get told to take 1,000 milligram tablet 2 times a day. 2 times a day. Okay, that's like almost max dose. If somebody starts out on this dose, they're gonna have terrible GI side effects and they're gonna stop taking it. So part of your teaching is, okay, you're gonna be starting on a low dose, take it with your meals. If you have an upset stomach and it lasts for more than a week or so, call your provider so we can maybe change it to an extended release formulation. Some people do better. And then this is just the caveat. Anyone who undergoes procedures, imaging procedures with dye, you might be the nurse who's doing the pre-op instructions for the patient. So anyone who's having a CT with contrast and they're on metformin, they have to not take them with metformin because they can have some renal destruction, because we need the kidneys to clear out the dye, and it's complicated when you're taking metformin. So used to lower blood sugars. There's very low risk of low blood sugars. It's like the lowest risk. I've actually never seen anyone have a low blood sugar on metformin in 10 years, 20 years of practice. Low blood sugar is listed as a potential side effect of the drug, but more common it's going to be these GI side effects. So biguanide, metformin. Sulfonylurea is a class where the pancreas has to be working. If the pancreas is no longer working, like in type 1, or someone who's had diabetes for a really long time. And if it's autoimmune, you can have some pancreatic cells working and producing insulin, but as the body is destroying it over time, they may eventually no longer produce any insulin. At that point, of course, we have to give them insulin. So your pancreas still has to be working. The ones that we use these days all start with this GLY beginning. And the way I think about it is these meds whip the pancreas to produce more insulin. And they're like, ka-chow, give me more insulin, ka-chow. And so there is a risk of hypoglycemia because one of those cracks of the whip, you may actually get too much insulin and your blood sugar will go low. So we do try and time them with the meals because of that, because we're stimulating the pancreas to squeeze out more insulin, which is, so that's why you still have to have a pancreas that works. So all of these glides, clemipuride, glipizide, glyburide, that's one way to remember them. Sulfonylurea. So it does have the potential side effect of hypoglycemia. So if you combine it with insulin, which has a risk of hypoglycemia, you have an increased risk of hypoglycemia. These ones, I don't think we're not going to really talk about them because they're not used really anymore. They, Starlix has a similar side effect to orlistat. Remember the side effect of orlistat, the wet farts? Yeah. Wet flatulent diarrhea leakage. So they weren't popular with the people who have diabetes. So that's why
I wonder why.
Yeah. So
They didn't like the wet part.
yeah, they don't like the wet farts too much, so they've fallen out of favor. Med is still produced because there are people who still take it, but so these TZDs are great drugs. These are insulin sensitizers. So they're not whipping the pancreas, they are stimulating our body cells to be more sensitive to the insulin that we are producing. So you can see these drugs start to have a different mechanisms of action to work, which is why we can combine them together and oftentimes get rid of the insulin itself as long as they're producing insulin. So by making our body more sensitive to insulin, obviously we decrease insulin resistance. That's the way to say the same thing. The only contraindication is for people who have, I would say, labile heart failure, but the manufacturer just says heart failure. So people who have pretty significant heart failure, we generally avoid them, and if we do put them on that, we're watching them closely for signs and symptoms of heart failure exacerbation, which are what? What are signs and symptoms? Right, signs of fluid overload, dyspnea, crackles, all of that stuff, edema. So those are the things we're watching. Yeah, weight gain, yeah, exactly. So TZDs, insulin sensitizers, pioglitazone, rosiglitazone. No, sorry, this is alpha glucosidase inhibitors. I apologize. Go back to here, glitidines. These are not used, and I forget why. They're similar to I told you the wrong things. These are not the wet farts. Sorry, alpha glucosidase inhibitors are wet farts, acarbose. It's all my bad. Ignore what I just said. I'm more of a man behind the curtain. So similar to orlistat in that it's delaying absorption, and you have to take it with meals, with the first bite of the meal, and the problems are the GI side effects, flatulence, diarrhea, weight gain. However, it doesn't cause hyperglycemia. Oh well. So if you don't want to have hypoglycemia and weight gain, but you don't mind flatulence and diarrhea and abdominal pain, I got a drug for you. We're going to take Precose or Glycet. Yeah. This came out maybe 10 years ago. They are pills that work in a completely different way. They act on the brain and the gut. They act on the brain to tell the brain that you are full sooner. You're satisfied. They talk about the satiety. You feel satiated earlier. You feel like, oh, I can stop eating now. And they also slow the movement of stuff, food within your GI system. So you're not going to get hungry as soon if you still have food in your stomach and your small intestine. That's two mechanisms to decrease the foods that you're eating. Now it does do some other things like increase insulin synthesis, but a lot of the activity is that brain-gut connection where we're teaching our brain is getting signals that you're satisfied. So the side effects of that would be obviously gut issues like feeling upset stomach, constipation, and it would be contraindicated in a diabetic who has gastroparesis. So if you have neurological damage to the GI tract because of your diabetes, well, we don't give you this drug that's going to slow the movement of your already slowed GI tract. So DPP-4s, they are great drugs. The sister to it is called GLP-1. So it's a complicated process, but these are like cousins. They work in different ways on similar mechanisms. GLP-1s are generally injectables. Say generally. In the book, they're all injectables, but we do now have an oral form. So they're like Victoza, Byetta, Ozempic. If you've ever seen the Ozempic, you've seen the Ozempic commercial. This is a GLP-1. People like it, even though it's an injection, because typically it's given once a week. And GLP-1s are known to induce weight loss. So it's another good drug that's not an insulin that helps address the underlying disease process of being overweight, inducing weight loss. In fact, one of the drugs in high dose is a weight loss drug. They just took the same drug and increased the dose and marketed it as a new drug with a new name and a new price, just for the weight loss. So it's an awesome one.
So why are these under anti-diabetics instead of anorexians?
Because they're used to treat diabetes.
Okay.
Yeah, there's just one, Saxenda, which is for weight loss.
Okay.
And it's listed in the chapter on CNS stimulants as one of the weight loss drugs, and it's just briefly mentioned, GLP-1. So the DPP-4s, they all end in gliptin, sitagliptin, saxagliptin, linagliptin, alogliptin. Yeah, we talked about, these are the side effects. They're weird. Increase the risk of an upper respiratory tract infection. You can have pancreatitis. And then GLP-1s we talked about. So they're injectable, they slow the gastric emptying, they address the issue with the brain. These are some of the brands on the market. This is the new one that's in oral Pharm that just came out on the market. These are the mechanisms of action. There is a risk for hypoglycemia. And then you have to screen people because it has a black box warning. It's kind of a weak association. There is a risk of developing a very, very specific thyroid type tumor. And so anyone who has a family history of it, we don't give it to them. Or if they've had a history of a thyroid tumor, right? And so all of these problems, we're slowing the GI tract. Generally, I teach patients from the very beginning, if you get the side effect where it's like morning sickness, and for men, you don't know what morning sickness feels like, but just imagine what morning sickness feels like. We treat this not by stopping the drug, but you need to eat less. The treatment for that upset stomach, vomiting, diarrhea caused from this GLP-1 is just eat less. Ha! It's one way. It's like antabuse that people don't want to drink because they have that disulfiram action. Well, people don't want to eat because if they eat too much, they'll be kind of sick. And this is like the average 5 to 10 pounds. This is the one that's for weight loss. And we now know that they have a mechanism of action that actually protects the heart and kidneys. It's an awesome drug. This is the newest on the market, SGLT2 inhibitors. It's actually a drug that makes you pee out sugar. That's the mechanism of action to get rid of your excess blood sugars. You pee it out. And so if you get a urinalysis on somebody on this drug, you'll get a urine glucose of, it'll say greater than 1,000. You'll be like, shut up. And then you'll look and you'll say, oh, okay, they're on Jardians. Okay, all right.
Oh, I've seen the commercials
Yeah.
for that. Yeah.
That's the mechanism of action. We eliminate it by just not even letting that sugar get absorbed anywhere. We're not worrying about the pancreas. We're not worrying about insulin. We tell the kidneys to excrete it, and we urinate it out. So you have to have fairly good kidney function still in order to use it, obviously. And then some of the risks associated with it are related to the fact that you have high levels of sugar in your urine now. You have high levels of sugar. Bacteria love to grow in dark, warm, sugary urine. It's a great place to grow. And then the flora that live in our perineal region, we have natural flora that live there. Because there's so much sugar right upstream, it's around there you can get genital yeast infections. You get in the folds of the skin, if they have a pannus under there, just because there's so much sugar in the area coming down. People can become hypovolemic and hypotensive because the way to get it out is to urinate it out. So you're urinating more. It's actually a diuretic. It's a diuretic using the power of glucose in order, so you're losing glucose, but you're also losing volume. And if we lose volume, we lose potassium. The great thing about it is, now that we know it's a diuretic, it has an indication in heart failure. This can be used on a patient who has no diabetes, but needs more diuresis. We use it as a heart failure drug. There is this FDA black box warning of something called necrotizing fasciitis.
Oh, that's so fun.
Yeah, so just basically, because this area is all sugary, and if you get a bacterial skin infection that isn't addressed, it may start to turn necrotic and black. So I haven't seen it, but I watch for it because that's the last thing you want is someone to have their genitals like necrotize off.
I have a friend that works at the hospital, and he had a patient a couple weeks ago that was like that, and it was the guy's whole like genital area, and they literally had to cut out pretty much everything but his penis.
Oh.
It was.
Yeah. It's.
Oh,
I
yeah.
mean, it's the black box warnings are real. They really do happen.
I mean, I don't think it was from, I don't know what it was from, but it was the fasciitis in that area, and I'm just like,
It's an unusual thing, so it would make me worried. So we educate patients about, good perineal hygiene and reporting signs and symptoms of urinary tract infection, and if they, if they're feeling lightheaded or dizzy, that they may need to increase their fluid intake. Awesome drug. Super, super.
So because of the fact that like sugar is such a large molecule, would you also be putting the patient at risk for having like internal like injuries through the ureters and areas like that?
No, you're not really. I mean, you're always at risk. Anytime you do anything with glucose, you're always at risk of causing acute kidney injury. Because we're making the mechanism of excreting glucose where usually it's maintained within our plasma. So anytime you're monkeying with the mechanism of the kidneys, you're at risk for causing damage. That's a good question. And then obviously if we're throwing off the electrolytes and the volume, we can end up in ketoacidosis. So lots of risks, but I love this. Patients don't like it though because it does make them pee. Just like any diuretic. This is to elevate your blood sugar, obviously. This is at home. I don't think patients need to go and buy glucose tablets. I don't know anybody in America who doesn't have a rapid-acting form of glucose in their home, whether it's a tablespoon of sugar or some juice or some Pepsi or some, you don't need to waste money on that. In the hospital, we give D5W, that's not supposed to be 50, it's supposed to be 5.
Hello, sugar.
Well, maybe it is D50. Yeah, this is hypoglycemia. Yeah,
Oh,
it
you're
actually
getting
is.
up faster.
D50, sorry. Yeah, this is somebody who comes in and their blood sugar's like 26, which is consistent with death. And you're just like, yeah, among all the things you're giving them sugar and insulin. These are the things you have to do. You have to check blood sugar before you inject anything into any diabetic patient because you can't get it back out again. Wow, these are injection sites. That was a bad picture. They talk about drawing up insulins in 2 types of syringes. That's really, really old school. I mean,
We are taught that.
Yeah,
it's
that's
just so, I've never once in 20 years taught anyone about mixing insulins.
I was like,
Never.
they still teach it because I have never done it in real life.
Nope, never.
I've been taught
But
in school 3 times.
it can be on an exam, just like any other thing that is like this random. I mean, granted, people may be on other insulins outside of a large metropolitan city area. And then just teaching about timing so that the basal insulin can be given any time of day as long as it's the same time of day, right? So that's this one. I don't care what time you give it. Just give it at the same time every day because it's a 24-hour acting medication. This is Lantus or Detamir or Basaglar, all of these long-acting insulins. So some people just get told take it at night, and they always forget to take it at night. So say take it in the morning. Well, they told me to take it at night. It doesn't matter. It's a basal insulin. Take it any time as long as it's the same time. Patient with type 1 diabetes is admitted with acute COPD disease. He's placed on IV piggyback antibiotics. He gets NEBs with albuterol. He's getting a steroid. He's taking a PPI for his GERD. He takes insulin glargine, which is your basal insulin. That's your long-acting. This evening, the nurse notes that his blood glucose is 170. The next morning, his glucose is 202. What is the most likely cause of his elevated glucose?
Corticosteroids.
Yeah, steroid. Now, it could be the disease itself, that he's actively ill. Anytime you're actively ill, all your patients who have diabetes, who are actively ill, have elevated blood sugars. But yeah, it's going to be the steroid. We know the steroid can shoot it way up. All right. What does that say? Steroids. All right. Adrenal drug. Oh, that's it for diabetes. So, insulin. Take a break. Stand up. Walk around. Adrenal gland there. So, we talk about. We're not talking about the adrenal medulla because that's epinephrine and norepinephrine. We've already talked about their functions. We're actually talking about the cortex, actually corticosteroids. They have a steroid format. So they fall into 2 categories: glucocorticoids, which are the steroids that we typically are thinking of as prednisone and prednisolone, things that fall into that class. The mineralocorticoids, it gets its name because they regulate the minerals, basically sodium and somewhat of potassium, a little bit of potassium. So their main job in the body is to replace what we're missing from, we don't have the mineralocorticoid. So what we're trying to do is, we don't have the effect of aldosterone, so we're losing, our electrolytes are off balance. There's only one in place that's of clinical significance, which is fludrocortisone. That's the only one you have to know about is fludrocortisone. We will talk about the steroids when we do the chapter on immunosuppressants. Oops, that's not the one. But let's see if I did it. Yeah. So, ooh, that's a horrible picture.
Oh, like, that's fun looking.
Yeah, so this is a lack of adrenocorticotropic hormones, and this is excess. So when we have excess secreted hormones, we end up with Cushing's. When we have less, we end up with Addison's. So if we have Cushing's, we're going to want to block the production of these adrenocortical hormones. If we don't have enough, we want to give replacement, and it's usually with fludrocortisone. There are varieties. Yeah, this is just sort of that same summary. So cortico-releasing hormone, just like we had thyroid-releasing hormone, we have corticotropic-releasing hormone, and then we get ACTH, and we get the production of cortisol and aldosterone, and we're not going to worry about that one. So lots of reasons we use it. I would just stick with adrenocortical deficiency. Unless it's the steroid we're talking about, because we do use the steroid in asthma, and they affect all. They don't just go and act on one body system. Unfortunately they act systemically. So yeah, drugs different. So I don't even want to go over that. Glucocorticoids inhibit control. Yeah, we'll talk about that when we get to the immune response. So this is what you should know about like the corticosteroids. So that's the glucocorticoids. They have a lot of long-term effects for people who are on them. In and of themselves, they can suppress the adrenal gland. We know that it leads to thinning of the bones, that it causes hyperglycemia and diabetes, heart disease, psych disturbances, and immunosuppression. And I don't have any idea what I put on that. So we're teaching people about if they're on a long-term corticosteroid, about some of these things that they're going to be monitored, blood sugar and heart disease and their bone health, because they're at such risk. That's why people who get put on a steroid, we try and keep it for the shortest period of time needed. All right, so this is not super important. Contraindications now. Basically knowing, so we're giving either a glucocorticoid or a mineralocorticoid, and that is coming from the adrenal cortex, and that the main drug is fludrocortisone. I think that's basically what you need to know. Oh, women's health. Wow, that was the end of that chapter, adrenal glands. Women's health, we do talk about estrogen and progesterone. That's just like the basics. Yeah. So we're going to talk about estrogen and progesterone. So we give estrogen when people have a condition and makes that they're estrogen deficient, and we're often either treating a symptom, which this is for women who've gone through menopause. They no longer have estrogen, so they have this sort of vagina that's dry and lacks the rugae. This is someone who is hypogonad, so they don't have well-developed reproductive hormone-producing organs. Obviously, we know that estrogen can be used with progestin for oral contraception. We can use estrogen for painful menses. It gets used in menopause. It gets used to stop uterine bleeding. We use it to strengthen bones. It's got like a ton of uses. However, it's not innocent. Estrogen is known to cause thrombolytic events, the worst, of course, being a stroke, especially if you are a smoker. Makes you at increased risk. So knowing the adverse effect, the most serious one is any sort of thrombolytic event, whether it's you get a DVT, a PE, an MI, a CVA. This is something teaching patients on estrogens that if it's topical estrogen and it's just vaginal estrogen, they're not going to have photosensitivity. People are taking oral estrogen because it's part of a contraceptive. We educate on photosensitivity, cause hypertension, inflammation of our vessels, and then all of the things that, so if we were using it to treat abnormal vaginal bleeding, then obviously a side effect of this can be lack of lack of uterine bleeding, right? Then we can have breakthrough bleeding. So we know what the main uses are. We use it in hot flashes and for women's bone strength and for contraception. And then the side effects, the worst one, are these thrombotic events. Progesterone we use for treatment of uterine bleeding for various reasons. It can be caused by uterine cancer, fibroids, hormone imbalances. We often use it in palliative treatment of some cancers in order to treat the bleeding, just so that people can have a quality of life. We're not solving the problem, we're just treating the symptom. We sometimes use it in the prevention if someone is threatening miscarriage, we have premature contractions and uterine bleeding. We may give a progestin, alleviate PMS. So typically, let's see, Megastrol. This is one you'll see if you do anything up at Huntsman, if you're working with any of the cancers. It's for palliative treatment of these metastatic, inoperable, recurrent breast and endometrial cancers, unfortunately. It also gets used for that weight loss that used to come with AIDS, because it stimulates appetite and promotes weight gain. However, the data says it's not very good, and it increases the risk for blood clots. So know the name Megastrol, that it's palliative, used for these sort of advanced cancer conditions. That's it on that. Contraceptives. Obviously, we know what contraceptives are. They want you to know that there are 3 types of contraceptives: monophasic, biphasic, and triphasic, meaning there are varying levels of hormones based on the week. So monophasic would have the exact same hormones every single week. Biphasic, it varies. You're going to have 2 weeks at one level and 2 weeks at another level. Triphasic most closely duplicates, as close as we can get, to a normal female cycle, where you have higher levels at one point of one hormone and then higher levels at another time. So just if they say, if the question is something like, the patient has contraceptive pills, and there's 7 that are yellow and 7 that are blue and 7 that are pink and 7 that are white. What type of contraceptive do they most likely have? Well, it's triphasic, because the white ones are blank, they're placebo, just in order to kind of hold your spate. We have newer ones that are extended cycle products, meaning that you don't have that blank, that you just keep taking them and never have a period. And they are estrogen progestin combinations. This pretty simple. We have problems because of the estrogen component. Again, here's the same things: hypertension and thromboembolic side effects. And these risks are worsened in stroke patients who smoke. So we often will not prescribe, or are very cautious in prescribing these to women who are smokers, because it just infinitely increases the risk of having a blood clot somewhere. And it really does come from the estrogen component. They get used, and so we can talk about osteoporosis. So estrogen can get used for osteoporosis, and so that's why this is brought up under women's health, although men get forgotten. Poor men get forgotten. They get osteoporosis too. It gets known familiarly. Women have menopause, and kind of in the medical world we joke that there's menopause, but that it's a normal loss of testosterone production, and that results in osteoporosis for men. And so we need to be screening both women and men, but they tuck it under women. So osteoporosis, obviously, so bone growth is a cycle of osteoblasts, which build, and osteoclasts, which break it down. Our bones are a dynamic structure that's always being created and broken down constantly. Unfortunately, after the age of 35, we have less osteoblasts building and more osteoclasts tearing down. So after the age of 35, we start to have, that's when we start to lose bone density. Normal aging process. So what we try to do is figure out, is there a way to interfere with this activity of blasts and clasts? So the main drug we use falls into the class called bisphosphonates. Fosamax was the first one on the market, alendronate Fosamax. And now we have more. It gets used for osteoporosis caused by glucocorticoids and then also this random bone disease. The trouble with it is these drugs are kind of like iron and potassium. They're super caustic on the gut. So the precaution is that they need to take it with a full glass of water and remain upright for 30 minutes. Otherwise, if they lie back, it's because it's very caustic and erosive, they can get those esophageal erosions. We never use it in anyone who doesn't have a good swallow. So if you have problems with the esophagus moving for whatever reason, or if you have a stricture, we don't give it in that case. We may use another drug, or we may give it by IV. This is a once-a-year drug, which we love. These ones are once a week. Lots of people love once a year. Go in, get an IV infusion, done, right? So and we also use it for like patients who are unable to follow this 30-minute upright. So patients who may have early dementia or combative or traumatic brain injury, we may give it another, because I've had wives of little old men who just don't want the battle every day every week to make him sit upright for 30 minutes and drink a full glass of fluid. It can be a battle if people have dementia. So bisphosphonates is first line. We go to these all the time. If somebody has been on a bisphosphonate and they have a fracture, then we consider it a treatment failure of a bisphosphonate and we go to another drug. Typically we go to this class of drug. And these are awesome drugs. This class of drug, bisphosphonates, basically works to prevent further loss. We're just trying to stabilize bone loss. Where if we don't have it, we have excess clasps, excess breakdown of bone, and our blasts can't keep up with it. So we're just trying to balance it out. You have osteoporosis, and we're just trying to hold it there. These drugs, teriparatide and denosumab, actually stimulate new bone formation. So you have more blast than clast activity. They're awesome drugs because they can give you better bone density. The problem with these ones is that it places you at increased risk for, atypical fractures, which are fractures that happen in a place where you wouldn't normally have it from a fall. Like typically when you fall, you're going to have a femoral neck fracture or a spinal fracture, and you may end up with a fracture in an unusual spot. For whatever reason, it just is not as strong as the areas it really does strengthen. Calcitonin, we talked about that being, calcitonin being produced here. We have the hypothalamus, the pituitary to and then we had calcitonin that regulates calcium. Well, sometimes we need to give calcitonin to inhibit this osteoclast. Oftentimes people come in, they've had a fall, they have an acute spinal fracture. They're not going to operate on it. They'll give them some calcitonin to return it around, and then they will put them on a bisphosphonate. SERMs I haven't seen SERMs used much. Raloxifene is out there. I typically stick with the first page or these ones, but know that there are some drugs that play with estrogen in order to increase bone density, right? We talked about lack of estrogen leads to bone health loss, loss of testosterone. So if we mess with that, we can increase bone density. Raloxifene, cool drugs. I don't think we need to need fertility pills. Let's see, I know that you need to know those ones. You may need to know oxytocin. Anyone who's had a baby or has had a wife may have heard of Pitocin, used to induce labor. So that's a uterine stimulant. Also, if somebody has had a miscarriage, but it's incomplete, we use it to, get the fetus out. I don't think you really need to know that one. Terbutaline is out there. It's a beta-2 adrenergic drug. Remember how we talked about there were uterine smooth muscle receptors, so we use actually a beta adrenergic drug to calm the uterus. So this one is to stimulate the uterus. This one is to calm the uterus. And mag sulfate is in the hospital. This is at home. This is in the hospital.
The magnesium sulfate is to treat preeclampsia, right? Is that
It's
what
used
it
to
is?
stop labor.
Oh, okay.
So there's no treatment for preeclampsia except giving birth.
I know that when they get to the hospital, they give them something, and I thought it was magnesium sulfate, but
I'm not
I might be
sure.
wrong.
I was given it when I was in the hospital for preeclampsia, but I almost want to say it was kind of like, maybe not preventative of keeping me from not going into labor.
Yeah.
But
Yeah, in this particular presentation of it, they presenting this as a uterine relaxant. So I think that's
Okay.
pretty much all you need to know about the mag sulfate is that this is an outpatient medicine, terbutaline, this is an inpatient medicine. Basically, that's all of women's health. Look at that, you're expert. Men, the main thing we talk about is testosterone replacement. Like estrogen, testosterone is not innocent, comes with significant risks. However, there are people who have hypogonadism. Either they've had born that way with lack of mature gonads, lack of the ability to produce sufficient testosterone, or have had an injury, kicked in the groin by a horse, and permanent damage where they no longer are producing sex hormones. Unfortunately, it does get misused off-label, I would say, for men to increase libido and all of that, but it's not a good use. We do use it to treat osteoporosis in men. All right, so testosterone, these are the two ones they talk about. This one is actually applied to the scrotum, and this one is just to the skin. And so I have seen a test question show up before talking about what do you tell them, and they'll either give you one or the other, and you have to know, tell them to apply it to the scrotum or tell them don't apply it to the scrotum. So know those. And then testosterone comes in lots of forms. It comes in gels, it comes in a patch, it comes IM, it's a super viscous, it's like honey almost, testosterone. You have to draw it up in a large bore syringe, and it's a big deep shot. So people have to really want that testosterone because it's a big shot. The only thing you should know about androgens, it's just synthetic steroids misused. Anabolic steroids are a scheduled drug, and it's solely because of that reason that they get misused. Where have you seen these drugs before? Yeah, they showed up again under Men's Health. So this is the cousin to, not the cousin. This is the one we saw, alpha adrenergic blockers, doxazocin, tamsulosin, terazosin, alfuzosin for BPH. Well, we have another drug out there, 5-alpha reductase inhibitors that are also used for BPH, finasteride and dutasteride. We also use it to treat male pattern baldness. The thing is that the main teaching point for this is that women of reproductive age shouldn't handle the medicine. So if you have a spouse or you're the nurse filling a pill box, please wear gloves. You should be wearing gloves anyways, but please don't touch. If you ever, we don't want any birth defects or miscarriages or anything like that. So this is the other drug that's used to ease the passage of urine, and there's lots of adverse effects. I mean, do you want to have man boobs or do you want to be able to pass your urine? It's a tough choice. We talked about those. Androgen receptor blockers. Oh, prostate cancer. Wait a minute. So if you've got prostate cancer, you're going to have excess production of hormone. So we're trying to block the hormone at the target tissue of the prostate. These are the meds we give. Men start having hot flashes like women. I would just say recognize that amide, flutamide. I've seen bicalutamide before. It's just know that it's an androgen blocker used in prostate cancer, and that you teach patients about the side effects of sexual problems and hot flashes. Let's see. I don't think you need to know that. Then erectile dysfunction, yeah, you don't need to know gonadotropin releasing hormones. You do need to know the ED drugs, right? What's the contraindication? Don't take it with any nitrates. So no isosorbide, no nitroglycerin. It is by relaxing the smooth muscle and vasodilation. These are the generic names, these are the brand names. You already know these drugs. These are the adverse effects. Because of vasodilation, you get, all of these are really related to vasodilation. Hypotension, headache, flushing. Just educate people. They want you to know about saw palmetto, herbal over-the-counter that is used for BPH. It does, if it's actually what's contained in it, it does actually have some of the 5-alpha reductase properties. So the finasteride and the dutasteride does have some ability, does come with some side effects. So if someone is being put on or doesn't want to be put on a prostate med, sometimes you'll see that they start taking saw palmetto. That's it, you get to go home. That was a lot, that was like 10 chapters.